Now, we're done with tachyarrhythmias. Any questions on them?
No, thank you.
Okay, so bradyarrhythmias are very easy. They're basically categorized based on which part of the conduction system is going wrong. It's either the sinoatrial node or the AV node or the bundle branches. This is how we classify them. Okay, so starting with the sinoatrial node, we have three types. It's either regular but slow. And remember, we said if it's regular and there's a P wave, but it's just too slow or too fast, it's immediately sinus bradycardia. Now, if there's no activity, zero activity, it's just a flat line, okay? It's like you have normal heart rate and then flat line in the middle, then it continues. It's called sinus arrest, okay? This one we'll get to it. So for AV block, these are really, really important. And I want to just go, okay. So like we said, it's classified based on if the problem is in the sinus node or the AV node or bundle branches. In the sinus node, we mentioned, this is what sinus bradycardia looks like. So the heart rate is usually 60 to 100. Less than 60 is bradycardia. You can see here how many squares, 1, 2, 3, 4, 5.5. So 300 divided by 5.5 is like 50 something. Okay, so this is bradycardia. There is a P wave, okay, and it's regular. It's just too slow. So it's a normal, everything is normal, it's just too slow. So this is sinus bradycardia. What if everything is normal, but then it stops suddenly, then it continues? It means sinus arrest. Like anything electrical or a device or batteries or electricity in general, it can have malfunction where it بيعلق شوي, Same thing can happen in the sinoatrial node. It just kind of pauses for a bit sometimes, Now, for bradytachy, which is you have bradycardia and then it switches to tachycardia. This can happen in normal inspiration and expiration. When you breathe in, your heart rate is a bit faster, and when you breathe out, it's a bit slower. Okay. This picture, by the way, is also sinus arrest. I don't know why it's here, but okay. So these are the three types. We'll do practice questions on them. They're very straightforward. Now for AV block, you have first degree, second degree, third degree, or this one's not too important. Just first degree, second degree, or third degree. Okay. First degree is, from the name, it's an AV block. So there's a delay, and even greater the delay in the AV node, which means that the PR segment is the one that's going to be affected, or the PR interval, not segment. PR interval is going to be the one that's affected in the ECG. So if you see here, the PR interval we said is usually 3 to 5 squares. Here, it's way more than that. It's about 6 squares, okay? So even more, so when you have a prolonged PR, it means we're dealing with an AV block, okay? The first degree AV block, it's just a prolonged PR. That's all you see, okay? You have a P wave, you have a QRS every time. P wave, QRS, P wave, QRS, everything is normal. It's just that the PR is prolonged. That's the only thing that you see. That's first degree. In the second degree, it's further divided into type 1 and type 2, okay? So second degree type 1, which is called Mobitz type 1, what happens is PR interval starts getting bigger with each contraction. To see here how the PR interval was small, then it got bigger, then it got even bigger, okay? Then you have a P wave and there's no QRS complex hatta here. It's kind of just dropped. So this is what we call a 1, 2, 3 drop, okay? So second degree type 1 is where the PR wave progressively gets longer until it just drops the beat. Okay, beat drop. We call this beat drop, okay? Or 1, 2, 3 drop. So it has other names, which is Mobitz type 1 or Rinke block. The second degree type 2 is the PR is fixed, okay? It's just there's a drop. Yani in first degree, PR is prolonged, but there is no drop in the beat. okay يعني no drop. Okay, in the second degree it's called, there's always a beat drop. Okay, always. Beat drop means we're automatically in second degree. Okay, what's a beat drop? It means the atrial contraction or depolarization did not reach the ventricles. So you'll see a P wave لحالها هيك, there's no QRS after it. So you either have type 1 or Mobitz 1 or type 2, which is Mobitz 2. Okay, in type 1 the PR can keeps getting longer and longer and longer, and then it drops a bit. But in type 2 the PR is the same, it's fixed, and you have a beat drop. Okay, in the third degree there's a disconnection between the atria and the ventricles. Like there's a P wave here, and then really far after it there's a QRS, and then there's a P wave here and there's no QRS, there's a P wave here, and then the QRS kind of follows it, not really. So the atrial depolarizations are not in sync with the ventricular. It's not P wave QRS, P wave QRS. No, they're kind of not in sync with each other. They're not really, okay, all over the place. Okay, so are these clear? Because these are really important.
Yes, it's clear.
Okay, so we talked about the sinus node dysfunction. We talked about AV node dysfunction. The third classification is if you have a problem with the bundle branches. Bundle branches are the ones that go to the right ventricle and left ventricle. You have a right bundle branch and a left bundle branch. Now, in order to recognize a right bundle branch block or a left bundle branch block, there are certain criteria. For the right bundle branch block and the left bundle branch blocks in general, we look at two leads, V1 and V6. Okay, so in the right bundle branch block, in V1, you'll have RSR. What does this mean? It means that you'll have an R wave, which is this one, an S, no, wait. Okay, you look at V1 and V6. Normally you have a Q, S, R. This is Q. This one is S. This one is R. So when I say R, S, R, it means that you have up, down.
Q in the image on the top.
Oh, sorry. Q, R. Okay, V1, V6. Sorry about that. Okay. So Q, R, S. This is Q. This one is R. This one is S. Okay. So when we say RSR, it means that you have an R wave, which is this one. So up. Then you have an S wave, which is this one. So it goes down. And then you have a capital R prime, which means you have another R wave, but it's bigger than the first one. Okay, so this is the pattern that you get. Okay, so if you know that QRS, this is an R wave, and this is the S wave. So RSR looks like this. Okay, so you have up, down, up on lead V1. On lead V6, you get QRS, which means you get a Q, which is this one, the dip down. Okay, you get an R and you get an S, same as the normal, just the S is a bit deeper. Okay, so this is just like memorization. Just know that when you see like this exaggerated M on V1, that you're probably dealing with the right bundle branch block. Okay, for the left bundle branch block, you'll see just a dip down in V1 and a little M in V6. This one. Okay, so this is mainly just like memorizing. Just memorize the criteria. Look at V1 and V6. Okay, for the right bundle branch, RSR, QRS. For the left bundle branch, it's RS and R. So inshallah, it will be really easy once you practice it. So here, what are we dealing with here?
Left bundle
think
branch.
Left bundle.
okay, why?
Because you see the deep S on V1 and V6.
Okay, you see the deep on V1.
Deep in V6.
And what do you see? And what do you see in V6? The M,
معلش.
صح?
Yeah, I was seeing the M. I was seeing V3. معلش.
Oh, okay. So again, when you're suspecting a bundle branch block, don't worry, you're not gonna just get a random ECG in the question and you're gonna be like, how do I know if this is bundle branch or ischemia or tachycardia? Where do I start? It's gonna be easy. The choices will show you what they want you to start looking at, okay? So for bundle branch blocks, look at V1 and V6. For the left bundle branch block, you'll see an M, like a notch, a high M on V6, and you see a dip down on V1. For the right bundle branch block, you'll see an exaggerated M, like this, okay? This one is a high M, and on V6, you'll just see like this. Okay, like kind of like a null segment, let me show you. Normal QRS. So it's mainly just memorizing صراحة. Just remember this. Left bundle branch block, it dips down on V1, has a high M on V6. Okay, very easy to spot, very easy to recognize. Now, what about this one? I know it's labeled this in there, just to apply the information. Does this apply here? I don't think so. Kind of, yeah. So this is right bundle branch, right? The reason is, you see the exaggerated M kind of goes like this. Okay. So there's like the notch up, and it goes back down, and it goes back up. It's not a normal one, because a normal one would start down, then up, and then it goes back down. This one, it starts up, it goes down, and it goes back up. Okay? Do you guys see?
Yes. I can't hear you. Yes.
Okay. So for right bundle branch block, okay, you tell me guys, what, I know I just said it, بس إنه what block is this?
Right bundle branch. You see the
Yes.
RF or
Exactly. In V1, what I was pointing at is, do you see these little notches that are up? They go up before the QRS. This is the difference. A normal ECG, this is the baseline. It starts down, goes up, and then goes back down. This one, it starts up. There's like this little notch, and then it goes down and goes back up again. Okay, this is an R, SR. So you have an R, then an S, and then another big R. Okay, so these are the tiny little, like, I hope you can see them. These, okay, in V1. And in V6, it's just a normal QRS. Okay, down, up, and down. See how this one dips down first? That's a Q wave, QRS. Is this clear?
Yes.
Okay. I hope, I don't know if I said this and you heard me, but like in questions, it will show you that they're asking for a bundle branch block. You won't have to figure it out of nowhere. Okay. So don't worry. The exam is very straightforward. Very, very straightforward. So, no, oh, just pretend I didn't see that. Okay, what's this? What's the first step in any ECG?
Rate.
Exactly. What's the rate here?
It's Brady.
Exactly. So how do we classify bradycardia?
Less than 60.
Exactly. It's less than 60. Means it's less than 60. It's classified based on SA node dysfunction, AV node dysfunction, and bundle branch blocks. So these are basically bradycardias. So where does this fall?
SA.
Yes, exactly. So what is this exactly?
Sinus tachy.
Yes,
قصدي sinus
sinus
brady,
brady.
sorry, sinus brady.
Yes, sinus brady. Why? Because you have a P wave, everything is normal, everything looks fine. You have a QRS, everything is there, and it's regular. When you have a P wave and it's regular, you think of sinus. So this is sinus bradycardia. Okay. What about this one?
Sinus arrest.
Exactly. So you have a P wave, a QRS, P wave, QRS, P wave, QRS, and then a rest in the middle, and then it continues. Okay. So this is called sinus arrest. This one is also the same. Okay, very easy to like figure out. Sinus pause or arrest, same thing. Okay. Arrest, I think, is like the entire thing would be flat. This one would be more accurately called a pause because it's just in the middle and then it continues. So sinus pause. What about this one?
First degree heart block.
Okay, how did you figure that out?
Because there's a long PR. But
Exactly. Exactly. And it's like the same. It doesn't get more and more. صح? It's a fixed PR. So if you look at the PR interval, it's really long. صح? Which means that you can hear me, right?
Yes.
Okay. So the PR is really long here. Okay, if you see the PR is really long, the space between the the P wave and the QRS, it's really, really long. So we know that the problem is that there's a delay in the AV node. There's AV nodal dysfunction, okay? And the way we classify AV nodal dysfunction, it's either first degree, second degree, or third degree. Okay, the second degree is classified into type 1 and type 2. In the first degree, it's a fixed, prolonged PR. In the second degree, it means we have a hard drop or a beat drop. Type 1, it's a 1, 2, 3 drop, which means the PR gets longer and longer and longer, and then it drops a beat. Drops a beat means it doesn't reach the ventricles. Type 2, it's a fixed PR interval. It's prolonged fixed PR interval, and it drops a beat. Third degree is when the SE node is not even like synchronized with the the AV node's not even synchronized with the ventricles. So the P wave is alone, the QRS is alone, they're not together. So this one falls into first degree because we have a prolonged PR or a really long PR, but it's fixed and there's no beat drops. When you see this this shape, no beat drops, and it's very regular, you immediately go to first degree, okay? What about this one?
Second degree type 1.
Exactly, second degree type 1 or Mobert's type 1, it's called. Why? Because if you look at the PR, it's getting longer and then longer and then longer. Do you see how this one is way longer than this one? This one is a bit longer than this one. So it's getting longer. And then here after the P wave, there's no QRS. It's a beat drop. Okay, it drops a beat, doesn't reach the ventricles. So 1, 2, 3, drop. Okay, so this is second degree type 1. Okay. Yeah, so not all atrial impulses are conducted to the ventricle. Now, what about this one?
Second degree type 2.
Exactly. So the reason we said this is a second degree type 2 is because the PR is prolonged, okay? And it drops a beat here, and it's not getting more and more prolonged, it's just prolonged, okay? So it's a fixed interval with a drop beat. That's second. What's this one?
Third degree.
Okay. Why?
Because the P and the Q RS aren't really like together.
Exactly. So this one can be a bit confusing, I understand. A way to kind of recognize this ECG is you'll see a P wave that's on its own. Okay, so this is a P wave on its own, and then you have a P wave here with a QRS, and then a QRS on its own with a little tiny P wave here. So it's very disorganized, you know, but you do have P waves and you do have QRS complexes. They're just not coming together. They're not coming after each other. Okay. So, okay, or you can look here. It's way clearer in this lead. You have a P wave and another P wave, but no QRS. And another P wave, no QRS, you know? And here the P wave and the QRS are so far apart. Then you have a P wave with no QRS, a P wave with a QRS, you know? So it's very unorganized. So this is a third degree. What about this one? I'll give you a hint. It's a bundle branch block. Is it left or right?
Left.
Left.
Left. Exactly. Why?
Because in V1, it's deep.
Exactly. And in V6, you have the notch here.
Yeah, the arm, yeah.
Yes, the notch. It kind of looks like this. Okay, perfect. What about this one? It's also a bundle branch block. Which one?
Right.
Right.
Exactly. Do you see this shape here? RSR. Okay. And in V6, it's just a normal QRS. So this is a right bundle branch block. What about this one?
No, but it's one.
Exactly. So you see how the PR is getting longer and longer, and then it drops a bit. What about this one?
Is this a junctional rhythm?
No, but I see why you
Right.
would think that. I see
Third
why you would.
degree.
Sorry?
Is it third degree?
Yes, it's third degree.
I
I'll show you the.
It's very faint.
Sorry?
The ECG is very faint, so you can't really see
I
the.
know. Yeah, this isn't the best ECG. This, what you can kind of see is, do you see this P wave on its own? And this P wave and this P wave, they're kind of really like not in sync. There's a P wave alone, so without a QRS. So I know it's not the best ECG, but just in case it comes, I'm including everything. So what about this one?
Sinus brady.
Exactly. So first step, you determine the rate. Okay, this is definitely bradycardia because it's less than 60 degrees. Second thing, it's regular. Third thing, you have a P wave, you have a QRS, no beat drops, no prolonged current intervals, no white QRS. Everything is normal. It's just a very slow heart rate. So that's a sinus. Okay. So any questions about bradyarrhythmias?
Nope.
Okay, so just in summary, these are the tachyarrhythmias that we discussed. This is kind of what you need to follow in order to diagnose. And these are the bradycardias we discussed, okay? Now, there are some bradycardias or tachycardias that they don't really fall into classifications, but they're like you can confuse them as a bradyarrhythmia and it can throw you off, but it's not really that. So these include extra beats. Now, what's extra beats? There are premature atrial contractions, premature junctional contractions, or premature ventricular contractions. Now, these we can't put them into tachycardia or bradycardia, even though sometimes when you look at the ECG, it could kind of look like tachycardia or bradycardia, but it's not. They're extra beats. They're kind of on their own. They're premature beats that can be from the atrium, the junctional, or ventricular. Now, from examples, you're gonna know how to differentiate them, inshallah. So this is just for practice. What is this rhythm? We'll do as many as possible just to make sure you understand.
Normal sinus rhythm.
Exactly normal. Everything is normal. We calculate the rate, it's normal. The rhythm is regular. P wave is there. PR interval is normal. QRS is normal. So it's a normal sinus rhythm. And be careful, in the exam, they do get you like an ECG and you have to know it's normal because they really care about in third year for you to be able to tell what's normal from what's not normal, more than diagnosing like complicated things and knowing ECG so well and understand. So at your level, it's really important that we know the difference between normal, not normal. So expect this on the exam and don't hesitate to choose normal. Okay. So do you guys want to take a break? And then continue? We did 3 lectures already, which was really good.
I think they're saying yes. And for Maghrib.
Okay, no problem. 10 minutes, is that enough? 10 minutes?
Yeah, sure.
Okay, cool. Okay, yalla, what's this one?
Sinus tachy.
Exactly. What about this one?
This one is a premature one, right?
I agree. It's sinus arrhythmia, but I agree, yes. What about this one?
Arrest.
Yes. Okay. Okay, yeah, you can call it arrest and pause. Okay, cool. What about these?
Mobits 2 in the top one.
Movits 2. Why do you think it's Movits 2?
Like the first one is أمزح. والله أمزح. Never mind.
مربط one first degree.
It's not Movits.
It's arrhythmia, the sinus, the one with the inspiration and expiration.
Yes, exactly. Do you see how these are close and then far? It's tachybrady. So you have tachyarrhythmia and then brady. This happens on inspiration and expiration. Okay? So when you inspire, your heart rate's a bit faster. When you expire, it's a bit faster. Okay? So even if you see her, same thing. Now, when do we call it sick sinus syndrome? It's this one, okay? When it's tachycardia, then there's arrest in the middle, and then bradycardia. This is 6 sinus syndrome, okay? What about this one?
Atrial tachycardia.
Okay, I see why you would think that, but
Or
think
atrial.
something else.
It's an atrial thing because the P wave.
Oh, it is atrial. What do we call this one? It's coming too early.
It's the premature atrial contraction.
Yes, exactly. Do you see how the space between this one and this one it's normal, and this one and this one they're all the same, but this one came a bit too early, almost, you know? But the rest are regular. It's regular. It's just this one is too early. I would say this one is also premature. Okay? Yes, exactly. They see how it's supposed to come here, but it came a bit too early. So the premature atrial contraction. Okay, what about this one?
tachycardia.
Yes, exactly. What about this one? Okay, it's already labeled, but this is atrial tachycardia, same as this. Normal, everything is normal. It's just too fast. Okay. What about this one?
Flutter, atrial flutter.
Atrial.
Exactly. It's the sawtooth, atrial flutter.
Yeah.
Also looks like this. Also this one. Okay, be very familiar with how these look like. What about this one?
Atrial fibrillation.
Atrial.
Exactly. Yes, you have vibrations, 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 and then a ventricular contraction, then vibration, so AFib. This is also how it looks like, okay? Just be very familiar with how it looks like. What about this one?
Same.
Also atrial
Exactly.
fibrillation.
Yes. I put them after each other because I don't want you to hesitate if it's the same thing. Now, when we're done with bradycardias, tachyarrhythmias, and all of that, there's one more thing that we need to know is junctional rhythms. Now, we know that the SA node, when it's the one controlling the rhythm of the heart, it's around 60 to 100. But sometimes the SA node malfunctions or there's SA node dysfunction. So what happens is the AV node takes over as the new pacemaker. Sorry? Can you hear me?
Yes, yes.
Okay. So when the SA node is not working sometimes, the AV node takes over as the new pacemaker of the heart. But the AV node cannot fire impulses at the same rate as the SA node. So when the AV node takes over and controls the rhythm of the heart, it fires at 40 to 60. Okay? And you will not have a P wave. Okay? So you'll not have a P wave, but it will be a regular rhythm. It looks kind of normal. It's just there's no P wave. That's a junctional rhythm. It means it's coming from the junction between the atria and the ventricles, which is like the AV node. Okay? So a junctional rhythm is 40 to 60 beats per minute. Accelerated junctional rhythm is 60 to 100. Junctional tachycardia is more than 100. Supraventricular tachycardia, which is the one we discussed before, is 150 to 250. And then we have premature junctional contraction. So this isn't the most high yield, but you might get one just to recognize what a junctional rhythm looks like. Okay. So what's this?
Premature junctional.
Yes, it's premature junctional contraction. Now, why is it not a premature atrial contraction?
Because there is no P wave.
Exactly. So you see how this is regular, but then this one comes too early, and it doesn't even come with a P node. I mean, a P wave. Okay, so this one is premature, and it doesn't have a P wave. So this is a premature junctional contraction, which means that you have like a normal rhythm. It's just that there was an impulse sent from the AV node was a bit too early, and it kind of disturbed the normal rhythm of the heart. So this is a premature junctional contraction because it does not have a P wave. What about this one?
This is a junctional rhythm.
Exactly. So if you measure the heart rate, 1, 2, 3, 4, 5, 6, this is 300 divided by 6, which is 50, okay? And we said that it's 40 to 60, the one that's produced by the AV node. And most importantly, there is no P wave, okay? Which makes sense because it's not being produced by the SA node and causing atrial contractions. No, it's being produced by the AV node. So if this looks like a normal rhythm at 40 to 60 beats per minute with no P wave, think junctional rhythm. Okay, which means it's the rhythm produced when the AV node takes over.
So I have a question.
Yes, go ahead.
When you have a junctional rhythm and the pacemaker comes from like whatever's below the SA node, would that mean that with every beat the atria isn't contracting at all?
Yes, because there's no P wave. There's
So
no,
it's just passive filling, وبعدين the ventricle just pumps out whatever?
yes, exactly. Because if there is no P wave, then you know that no atrial contraction. Okay,
Mm-hmm. Okay, thank you.
no problem. Okay, what's this one?
Functional tachy? I don't know if that's a thing.
Okay, remember the table? This one? This is the naming of them. Its junctional rhythm, accelerated junctional is 60 to 100. More than 100 is junctional tachycardia.
So it's
So
accelerated.
exactly, it's accelerated because there's no P wave, but everything else is normal, and it's 70. No, it's 70, which means it's more than 60, so it's accelerated. What about this one?
Junctional tachy.
Exactly, because there's no P wave and it's more than 100 beats per minute. What about this one?
Supraventricular.
Okay, why?
Because it's يعني the heart rate is 150 and above, and also there is no P wave at all.
Exactly, exactly. It's the same one we talked about in the beginning. No P wave, more than 150, supraventricular tachycardia. Same thing here, okay? No. What's this one?
Premature ventricular contraction.
Exactly. So this one, it's not premature atrial. This one is the premature beat. First of all, it's not premature atrial because there's no P wave, okay? And it's not premature junctional because there is an abnormality in the QRS, which means that the QRS or the ventricles are not pumping properly. There's something wrong with the ventricles. So this is actually a premature ventricular beat, which means that this impulse, this weird impulse that came in the middle here, was from ectopic tissue in the ventricles. Sometimes you have ectopic tissue, which means tissue that's not supposed to be there, and it sometimes sends out random electricity. Okay, so that's why the QRS complex is very weird looking. Okay, because it's not a normal ventricular contraction. So everything else is normal, but then in the middle it got disturbed. There was like a weird premature impulse, and it came from the ventricles. Okay, so it's a premature ventricular contraction. You see how there's like ectopic tissue here, and this one is the one that sent out like an early signal, and it gave a weird beat in the middle. What about this one? Honestly, this one is really low yield. I don't know, like probably never heard of it before. Very low yield. It's also coming from the ventricles. That's why the QRS looks very weird. Just know it just in case it comes. Okay, what's this one?
Ventricular tachy?
Exactly. White QRS, regular beats, ventricular tachycardia. Okay, this is so characteristic. Like this look, where it's just regular wide QRS, ventricular tachycardia immediately. Okay. Okay, what about this one?
VFib.
Yes. There is no proper QRS complexes, no P waves, no nothing, no pattern being followed. This is ventricular fibrillation. What about this one?
Also VFib.
Yes, exactly. This one?
Cardiac arrest.
Yes, or asystole. There is no beating the heart. Okay, now this is a heart block, but which one?
First degree.
Exactly. Why? Because,
And PR.
yes, do you see how long the PR complex, or I mean the PR interval is? It's really, really elongated, but it's fixed. It's not getting longer. There's no beat drop, no nothing, so it's first degree. What about this one?
Mobitz type 1.
Exactly. So it's getting longer, longer, and longer, and then it drops a bit. Okay, what about this one?
Mobitz 2.
Okay, why? Because first of all, you have a beat drop here. So we know we're dealing with second degree. And then we check the PR. Is it fixed or not? It's fixed. So it's second degree type 2 or Mobitz 2. Now what about this one?
Third degree. Is it third degree? Yeah, it is.
Yes, yes. Why? Because they see this P wave, it's alone. And then this P wave is really close to the QRS. This P wave is really far from the QRS. This one in the middle. So the P waves aren't synchronized with the QRS complexes. This is a third degree. Same thing here. Okay, what about this one?
This is junctional tachy.
Yes, exactly. There's no P wave, and the heart rate is 60, wait, no, it's more than 100, صح? Because it's 2.5 squares, so it's junctional tachycardia. Most, like the biggest giveaways, there's no P, okay? What about this one?
Premature atrial contraction.
Exactly. So if you notice, this one is coming in too soon. Like this is regular, 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 regular. Like it looks very regular, and this one is like coming in a bit too early, and it has a P wave. So there is atrial contraction. So this is a premature atrial contraction. Okay. What about this one?
SVT.
Exactly. So no P waves, and it's more than 150 SVT. Okay. So this is just a summary of everything we talked about. If you want to take away anything from these 2 hours, it's this summary, and this summary. This is basically the first 3 lectures, is these 3 tables or summaries. Okay. Now, do you have any questions, whether it's from the beginning of the lecture, determining the axis, what do the leads mean, anything before we continue? We're almost done, inshallah. Okay, I hope it's all clear. Now, going back to this, which is very important, we're going to start with the acute coronary syndromes. For acute coronary syndromes or ischemic heart disease, the main thing you need to know, or you have to know for this lecture, is knowing which leads show you which part of the heart, and then the blood supply, okay? If you just know these two, خلاص, you'll like be able to kind of read any ECG, inshallah. Now, acute coronary syndrome, you have 3 types or 3 stages. You have STEMI and STEMI, unstable angina, and stable angina. The way this starts, you start off with a stable angina. What's a stable angina, or what's angina first? Angina or angina pectoris is basically chest pain. Okay, so a stable angina, it means you have in your blood vessel or in your coronary artery a plaque from atherosclerosis, but it's not ruptured, it's not moving, it's not causing blood clots, it's just there. It's just there, just sitting there. So it's stable, okay? And basically, for a stable angina, the way this comes in questions, they'll tell you that there is shortness of breath or pain or chest pain on exertion or on exercise or when he moves too much or when he exerts too much. But when he's resting, he feels fine, okay? So the symptoms are very predictable. It's just that when he exerts, there is pain, there is shortness of breath. When he's at rest, there are no symptoms, okay? The reason is because the blood flow can still reach the heart. It can still supply the heart. But when he is running, for example, or exerting, the blood demand or oxygen demand to the heart increases. So like it can't keep up. This tiny space cannot keep up with how much blood supply he needs when he moves a lot. So at rest, no symptoms. When he's moving, symptomatic. That's a stable angina. A stable angina can turn into an unstable angina. The reason we call it unstable is because the symptoms are very unpredictable. It comes suddenly, then it goes away, stuff like that. The reason is because this plaque ruptured, okay? It's now ruptured. And when a plaque ruptures, it causes blood clots because it induces inflammation and blood clot formation, everything. So now you have blood clots. So suddenly your blood vessel will clot, and then the clot will move. It will clot another part, it will move, you know? So it's very unstable, very unpredictable symptoms, okay? Now, an unstable angina can progress into an NSTEMI. What's an NSTEMI? It's a non-ST elevation myocardial infarction. An NSTEMI means that there's a partial occlusion of the blood vessel, okay? But you're gonna say, well, there's also partial occlusion here. There's also partial occlusion here. What's the difference in an NSTEMI? In an NSTEMI is where we start seeing ischemia in the actual tissue of the heart muscle. So you have subendocardial ischemia. So you have the heart. This is a chamber. Subendocardial ischemia is this part over here. Why? Because the coronary arteries are on the outside. So when you have reduced blood flow or occlusions in the coronary arteries, the first part to get affected is the innermost part of the muscle because it's the furthest from the blood supply. So an NSTEMI is when you have a partial occlusion in the blood vessels, which leads to subendocardial ischemia, okay? An NSTEMI can progress into a STEMI, which is where we have total, but it's very, like, you don't usually have an NSTEMI that progresses into a STEMI. You usually just jump to a STEMI, you know? But it can progress into a STEMI, which is where you have total occlusion of a vessel or of the coronary artery. And with the total occlusion, you have transmural ischemia, which means the full thickness of the wall becomes ischemic. Okay, so let's start again. Stable angina means unruptured plaque, shortness of breath on exertion. Unstable angina, you have a ruptured plaque, you have a shortness of breath even on rest. Now, question for you guys, can we see these on ECGs, the angina and unstable angina? Do you think we can see them on an ECG?
Yes.
Why?
You asked for unstable and NSTEMI, right?
No, unstable and stable, these two. Can we see them on ECGs?
Unstable, but not stable.
Okay, so actually we can't see them. Why? Because the only thing that translates onto an ECG paper is if you start to have damage to the actual heart muscle. In angina, even if it's stable or unstable, the heart muscle is still not affected. You only start seeing ischemia in the heart muscle when you get to NSTEMI. Okay? So once you see signs on the ECG, it means that you have already reached myocardial ischemia. Okay? Here it's just blood occlusion, but the heart is still viable fully. Okay? So when we start seeing changes on the ECG, it means that now you've reached the stage where there's ischemia to the myocardium. Okay, that's why you only see an end STEMI and the STEMI on ECGs. Now, what do you see on ECGs? On ECGs, the first phase of myocardial injury, the beginning of ischemia, you start to see a T-wave inversion. Okay? Next, you start to see an ST depression, and we go into detail onto how to notice these things. Okay? ST depression means you have subendocardial ischemia, which is what we said here. Remember, we said here when you have partial occlusion of a vessel or an artery or a coronary artery, when you have partial occlusion, the first part that gets affected is the subendocardial tissue, which is the furthest away from the blood supply, because the blood supply is outside. The way subendocardial ischemia translates on an ECG paper is that it will give you an ST depression. Okay, this is an NSTEMI. Then it can progress into an ST elevation. What does ST elevation signify or mean? It means that the transmural or full thickness of the wall is ischemic now, which means there's full occlusion of the vessel, which means it's a STEMI. Okay, from the name, STEMI means ST elevation, infarction, and STEMI non-ST elevation. So this one's because of partial occlusion or subendocardial ischemia. This one's because of transmural. Now, deep Q wave, okay, means that the tissue is gone. Like at this stage where we have ischemia, if you do reperfusion to the heart and you treat everything, the heart can go back to normal. But when you start seeing Q waves, it means that there's irreversible tissue damage to the heart. Okay, to the tissue. It's not just ischemia, it's like the tissue is going away. Okay? So this is what I explained in the beginning. So yeah, let's start. The first thing you see is T-wave inversion. This is a normal T-wave. It's supposed to be up. The first sign of ischemic damage is the T-wave will be inverted. Okay? Second sign is ST depression. So this is the normal level of the ECG. The ST, see how it's below the line? This is an ST depression, okay? Which means, or it signifies an NSTEMI. For NSTEMI, it means ST depression, okay? Which means subendocardial tissue. Now, this is an ST elevation. So this is the level. You see how it's elevated, it's above the line. So this is an ST elevation, which means that this is a transmural, or the full thickness of the wall is ischemic. We're still at the reversible stage though. When you start to see a Q wave, which is this over here, okay? The Q wave, remember how we have Q, R, S? This Q wave will be so deep, more than 25% or deeper than 25% of the R wave. That's a Q wave, and it means that you lost the tissue. It's like really damaged tissue, okay? So this is a normal one, okay? Like we said, you start with inverted T wave, it becomes a depressed ST segment, then it goes into elevated ST segment, okay? Same thing here. Okay, are these concepts clear before we start the ECGs?
Yes.
Okay, so the most important thing to understand is that you need to know which leads are like, you need to know which leads correspond to which part of the heart, okay? Now, if you noticed when I showed you the leads here, there's a side of the heart that's missing, which is the posterior side, okay? So how do we know if there is damage to the posterior side of the heart? We actually look at reciprocal changes. What's a reciprocal change? It means that when you have a STEMI in for example, lead 1 and AVL, you have an ST elevation, okay? In the mirror leads, which are lead 3 and AVF, which are the leads that are like mirror images of one AVL, it will present as a depression, okay? That's how it works. So when you have a depression in V1 and V2, this is suspicious for a posterior STEMI because we don't have leads for the posterior side of the heart. Like as a normal routine. We can add lead 7, lead 8, lead 9, we can add leads to the back of the heart, but we don't do that on routine examination. We only do that when we're suspecting a posterior STEMI. And how do we suspect a posterior STEMI? Is when we see an ST depression on the mirror leads. The mirroring leads to the posterior side of the heart are V1 and V2. They're right in the front. V1 and V2 are right in the front of the heart. They're placed at the septum, okay, front of the chest. So they're like mirroring images to the posterior leads. So when we see a depression here, it means there's probably an elevation on the mirror ones. Do you get this concept?
Yes.
Okay, so like here, for example, if you look at V1 and V2, this is the isoelectric line. If you can see, there's an ST depression. This isn't the isoelectric line, there's an ST depression. So this made the physician, for example, suspect that there might be a posterior wall MI. So he added more leads. He added V7 and V8 and V9. Where is it? They're not showing 7, but you add 7, 8, and 9 here. These are the positions of lead 7, 8, and 9. So they add these leads to the back, and it really did show an ST elevation. See, this is the elevation right here. Okay, so this confirms posterior MI. Now, we talked about, okay, STEMI means ST elevation, but what is exactly an ST elevation? How do you make sure there is an ST elevation on the lead? You look at the J point, which is this one. Normally, when you have the ECG, you have Q, you have R, you have S. Where the S meets the isoelectric line, this is the J point. If this J point is above the isoelectric line, like if it's here, this is an ST elevation. Okay, this is what they're telling. This is how an ST elevation looks like. So it would look something like this. Instead of continuing back down, it continues back up. So this is where the ST elevation is, okay? So again, normally you have Q, R, S, and then T. This is the ST segment. If we have an ST segment elevation, this part here will be up, okay? And this segment would be up, which is what they're telling you here, okay? Now, how high does this have to be for it to be considered an ST elevation? It has to be more than or equal to 1 millimeter in 2 consecutive leads or more. 1 millimeter is 1 square, so it has to be an elevation of at least 1 square or more for it to be considered an ST elevation, okay? So this area right here, just clear. This space right here has to be at least 1 small square for it to be considered an ST elevation, okay? And it has to be in 2 or more consecutive leads. We'll discuss what that means. Now, I'll go back to this. No, I can't. Okay. So we said that the definition of a STEMI is when the J point is 1 square or more above the isoelectric line, in 2 or more consecutive leads. But what about leads V2 and V3? The reason why V2 and V3 have a different criteria is because even in a normal ECG, V2 and V3, they kind of have an ST elevation. They kind of look like this sometimes, okay? Like normally there is kind of a slight ST elevation if you look at V2 and V3. That's why the criteria for V2 and V3 is more than 1 square. In women, it has to be 0.15, it has to be 0.2 in men 40 or older, it has to be 0.25 in men less than. This is not that important, to be honest, because you're not going to count tiny squares in the exam. You just have to recognize if it's a STEMI or not. But the reason that in V2 and V3 we have even more criteria, or we need more than 1 square, not just 1 square at least, no, it has to be 1.5 squares or more, is because even in a normal ECG, there is kind of an elevation. So you can't really say, oh, there's 1 square here, elevation, yellow, this is an ST. No, because in V2 and V3, even in normal ECGs, it has that elevation. That's why the criteria is 0.15 or more, not 0.1, okay? So if you look at this one here, what do you see? Okay, we can go back to this later if you want, but let's finish the morphology. So there are cases where you need to differentiate between an ST and an actual ST and something that resembles an ST, which is like in the case of pericarditis, where the ST it looks like an ST, but it's actually like this. So what they're trying to tell you is an ST elevation will be concave. Concave is like this, convex is like this, okay? So it will be, no, sorry. This is convex, this is concave. So in a STEMI, it's gonna be convex, like this. In a pericarditis, it's gonna curve outwards. So it's gonna be concave. Okay, this is how you can kind of differentiate them. Like we said, a really deep Q wave, a Q wave that's more than 1/4 of the S wave, deeper, it means that there's a lot of irreversible damage in the muscle, okay? And it can stay there. Like you can get an ECG and all of it is just abnormal Q waves, but there are no STEMIs. This means this is an old MI because it stays there. The Q wave stays there, okay? So this is what we talked about. Now, this is the most important part is they'll give you an ECG and they'll tell you which side of the heart is affected, or which side of the heart is ischemic, or which artery is the one affected, just by looking at the ECG. How do you figure that out? You need to memorize this. Okay, you need to memorize this. You have to. Okay, same one as the one I showed you in the beginning. Now, like we said, a STEMI is an ST elevation of more than 1 square in 2 consecutive leads. So let's say you saw a STEMI, I showed you an ECG, you saw a STEMI in V1 but not V2. You cannot call it septal, okay? Let's say you saw a STEMI in V3 but not V4, you cannot call it anterior, okay? Let's say you saw it in V5 but not V6, you cannot call it lateral. It has to be in 2 consecutive leads, okay? So in order to call it a septal MI, you need to see a STEMI in V1 and V2. In order to call it an anterior MI, you need to see a STEMI in V3 and V4 in order to call it, so on, okay? Same thing with lateral. You need to see it in I and AVL. I and AVL are considered consecutive. In inferior, you need to see it in at least one of the, at least 2 of these, okay, to call it inferior MI, okay? In posterior, like we said, you would see a depression or an ST depression in V1, V2, and stuff like that. So this is, you have to know this, okay? In the exam, you have to know this. A really easy way to know this is just kind of know how the picture looks like. So draw it out in the exam. Lead 1, lead 2, lead 3, AVR, AVL, and AVF. Then V1, V2, V3, V4, V5, and V6. These, okay, are right coronary artery. And then these, I can't show you, they're basically, like this is an L and then an inverted L. These are right coronary artery. These are the LAD. Okay, rest is circumflex. This is how I kind of memorize them, is that you draw an L and then you draw an opposite L on the leads, and these are like how you can memorize them, okay? This is just more anatomy. Now, this is how questions are gonna come. So who can solve this? You can try, you make mistakes now, it's better than later.
I can.
Okay, go ahead.
So I can see that there is an ST elevation from V2.
So it is B. You can see
Yeah.
here in
Yes, tell me which leads are affected.
From V1 to V6.
V1 to V6. Okay, I agree. V1, V2, V3, V4, V5, V6. Let's look at them. So This is the isoelectric point. There is an elevation here, yes. In V2, this is the isoelectric point, yes. This is the elevation. V3, this is the isoelectric point. Yes, there is an elevation, very big one. In V4, this is the isoelectric point. This is the elevation. Isoelectric point, elevation. And in V6, I agree. It's like 1.5 squares, just it's there. So it's right here. This is elevation. Okay. What else? Where else do you see it?
Very slightly in AVL.
Yes, exactly. So this is the isoelectric line. There is an elevation. Okay, I agree. Where there's one more.
Lead one.
Lead one, yes, exactly. So if you can see, this is the line. It's elevated here. Okay, there's a space here. There's a space here. So you have lead one and AVL. One and AVL means which side of the heart? Lateral, صح? So we're sure no, there is lateral because it's we see a STEMI in 2 consecutive leads, and we said for lateral. Sorry, we said for lateral, 1 and AVL are considered consecutive leads. Okay. So we know for sure there's lateral. Can you hear me?
Yes, yes.
Okay. Now we also can see we see a STEMI in all. Okay, in the septal and the anterior. In my opinion, like extensive anterior, because all the leads have a STEMI in them, but this one also works. It's the closest. The anterior leads have a STEMI and the lateral leads have a STEMI. Okay. Another way to look at this, let's say you didn't notice 1 and AVL. 5 and 6 can also give the lateral STEMI. But let's say, for example, I'll give you a scenario where, let's say there's no STEMI in 6. Okay? There's no STEMI in 6. So just looking at these leads, not say lateral, because lateral means 2 consecutive leads. So it has to be V5 and V6. Okay? So by looking at V1 to V6 alone, and ignore these for now, you cannot say it's lateral. Just stressing on the concept, it has to be 2 consecutive leads. Okay? So you can either look at 5 and 6. If they both have a STEMI, then you can say it's lateral. Or you can look at 1 and AVL. If they both have a STEMI, then you can say it's lateral.
طب I have a question.
Yes, go ahead.
يعني لازم إنه يعني for example يعني to say lateral يعني lead 1, lead AVL, lead 5 and lead V6 يعني all the 4 leads should be يعني STEMI, right? To say lateral.
No. It can either be 5 and 6
or
1 and 8.
Okay, تمام.
These two are together, have to have a STEMI together, or 5 and 6.
Okay, تمام.
Okay, تمام. Okay, here they're just telling you all of these are considered anterior STEMIs. Now, what about this one? I'll zoom in. Sorry?
Lateral STEMI.
Okay, there is lateral involvement. Which leads made you say, okay, there is lateral wall involvement?
One and AVL.
Okay, they're very slight here. But yeah, I agree. There is an elevation here and here. Or
There's more
I disagree.
anterior. There is lateral.
Yes, I see personally. I see in V3. I see in
four.
V2. V4 صح. حتى V5. V6.
V6, yeah.
Yes. So what do we call this?
Anterior lateral.
Exactly. Extensive anterolateral. The difference between anterolateral and extensive anterolateral is extensive anterolateral means all the anterior leads are involved. Okay. Now, what about this one? I give you a hint.
Lateral stem.
Lateral. That's one.
Yes. Yes.
Lateral.
So you see how this one, there's an
Yeah.
yes, elevation here and elevation here.
Yeah,
Or
lateral.
maybe you didn't notice this. You can even see them in 5 and 6. Okay. There's no semi in 4. I don't see it in 4. It's very minor. Maybe like here. So yeah, this is lateral. Okay. What about this one?
Inferior.
Inferior. Inferior.
Okay, why?
Lead 2, 3, and AVF.
Okay, yes, lead to 3 and AVF. That's really correct. Okay. Perfect. Which artery is most likely involved?
RSA.
Okay, perfect. This is how questions will look like. Basically this and this from this lecture. Okay, what other ECG can help you in this diagnosis?
A 15.
Yes, a 15 lead, which is basically right-sided, صح? Now, the reason we said that is because the right side of the heart does not have electrodes. Do you remember how the electrodes are placed on the heart? They start from the middle and they go to the left. So you can't really read from the right side of the heart. So when you have an inferior STEMI, there's a concern that the right side of the heart might be involved because also it's supplied by the right coronary artery, which is the one that's involved. That's why when we have this case, what we do for the patient is we also do a right-sided ECG because the normal ECG is left-sided. Okay, so in the inferior MI, we are concerned that the right side of the heart might be involved because we have the RCA involved. So that's why we also do the right side, okay? So this is the normal electrodes. They're usually on the left side of the heart. What we do for the patient is we also add it to we do it for the right side and then we look. Okay, you see how we have STEMIs everywhere? So this confirms the diagnosis that there's a right-sided STEMI. Is this clear? Did I? Okay, cool. This is just extra information for you guys, how to recognize if someone is having a right ventricle infarction. Now, what about this one? We didn't talk about this yet. But if you can know this, it would be nice.
Early repolarization.
Yes, perfect. Now, this one has a very specific sign called a notch J point. Do you see the notch here? It's like this. This notch J point is specific for early repolarization. Okay, so just know this sign. What about this one?
Pericarditis?
Yes, exactly. Now, what's the criteria for pericarditis? You have diffuse ST elevation and PR depression. So if you see here, there are STEMIs everywhere. There's a STEMI here, STEMI here, STEMI here. Do you see how this is elevated? This is elevated. This is elevated. I see one here. Come on. There's also here, also here, also here, also here. So one of the signs of pericarditis is diffuse ST elevations. Second thing is you have PR depressions. Do you see how the PR segments are down? Do you see that?
Yes.
Yes, so you have PR depressions, diffuse ST elevations, and the ST elevations are more concave than convex. So I don't know if that helps. It's more convex than concave, or concave and convex. No, it's more like this than like this. Concave, yeah. I follow these two. These two are more accurate. It's hard to kind of tell concave and convex in the exam. So just remember PR depression and ST diffuse ST elevation. Now, these are differentials of ST elevation. Now, let me give you a scenario where a patient did an ECG that showed that he has STEMI, but then he did a second ECG and everything went away. What do you think this can be?
Can you repeat?
Where you have an ST elevation, but then it goes away.
Angina. Unstable angina.
Now remember, in angina, we don't have ST elevations or depressions. For this patient, you did an ECG, you saw a STEMI, but then it went away. Because an ECG is not just one heartbeat, it's many. So you see a STEMI, then it goes away.
It's the prismatic angina due to
Exactly.
a spasm.
Yes, so this one can present with an ST elevation, but then it goes away. Why? Because this is a spasm of the coronary artery. So the coronary artery will spasm, it will close, but then it's a spasm, so it will open back again, So we can confuse this with ischemia when it's not. Okay, what about this one?
This is an NSTEMI.
Okay, perfect. For NSTEMIs, you don't need to locate them. Just know it's an NSTEMI. Why is it an NSTEMI? Because you see the ST depressions. Where do you see ST depressions? In which lead?
V3,
Yes.
AVL, and 1.
Okay, I just want to make sure. Don't confuse this with an NSTEMI. The NSTEMI is here. You see the space? It's below. So you draw the line. This one is below the line. That's an NSTEMI. Okay. So what about this one?
Anterior STEMI.
There is anterior. What else?
Lateral?
Yes, exactly. Which leads did you see that?
2 and AVL.
No, 1 in AVL.
Oh, yeah.
Yes.
Okay. Sorry, I got it. Yeah, one of
No,
yeah.
it's okay. Yes. So 1 in AVL. Okay, and in V2 and V3 and V4, so it's anterior lateral. Okay, what about this one?
Also anterior lateral.
Yes.
Anterior. There's no lateral. Where did you see lateral?
5 and 6.
I assumed 5 and 6, or at least 5. 6 isn't that much.
6 is okay. I agree with you. There is kind of, yeah, it's like 2 squares. I agree with you. There is slightly in, oh, this is 5. Let me see 6. Okay. Is there an ST elevation in 6?
A little bit. It's very tiny.
It's less than a square, right?
Okay. Okay. Yeah.
Yeah. It's so tiny. So barely, like if you draw the straight line, it's this. So it's barely, like you look at the J point, which is this point here. I know if, don't look at this part. If you look at this part, it looks elevated. I know, but you need to look at the, oops. This card, okay. You need to look at the J point, which is this point right here. This is where you look at this to me. And it looks very even on the same line, okay? So I only see it very clearly in 5. So if it's not 5 and 6, we cannot call it lateral, okay? It needs to be 2 consecutive leads. Is that clear?
Yes.
Okay. Now there are many examples, but we don't have time to go through them. They are in the PowerPoint, so I'll go through them, and if you have any questions, let me know. I'm more than happy to solve them with you. This is just for the sake of the recording, because it's taking so long. Okay, last part of the lecture is atrial enlargement and ventricular hypertrophy. Now, the atrial tissue is really thin. So when there's overload, it just stretches out, okay? But when there's pressure overload on the ventricles, they become hypertrophied, very thick, okay? And we can see these changes on the ECG. Okay, so this is the point of the lecture. We can see atrial enlargement and we can see ventricular hypertrophy. Now, atrial enlargement, how to detect atrial enlargement? We look at P wave changes. And to detect ventricular hypertrophy, we look at QRS changes. Now, the P wave in general, is 2.5 by, like 2.5 by 2.5 is an easy way to remember it. It's usually 2.5 millimeters wide and 2.5 millimeters tall, okay? Or 2.5 squares by 2.5 squares. That's kind of the average size of a normal P wave. Now, what happens with left atrial enlargement is this. Usually, the P wave, this side of the P wave is for right atrium, and this side of the P wave is for the left atrium. Because remember, it's as if the patient is facing you. So this is the right, this is the left. So this side of the P wave actually signifies right atrial depolarization, while this side signifies left atrial depolarization. But they happen at the same time, تقريبا. They're very synchronized. That's why you see it as one wave. But let's say the left atrium starts to enlarge, okay? Without the right atrium, just left atrial enlargement. What happens is it's gonna take longer for the left atrium to depolarize. So instead of the wave being synchronized, it starts to look something like this. Why? Because the left atrium stops being synchronized with the right atrium. It takes longer to depolarize than the right atrium when we have left atrial enlargement. So the waves start to separate almost. So what you see is the mitrale, P mitrale sign. It looks like an M, okay? So this is what we see on lead 2. On lead V1, what happens is, normally on lead V1, the P wave looks something like this, okay? This side, again, represents the right atrium. This side represents the left atrium. So when we have left atrial enlargement, the left part is exaggerated. So it will look something like this. The left part is exaggerated, okay? So this is what we have here. For left atrial enlargement, we look at leads 2 and V1. On lead 2, you will see the M that we talked about, okay? And the space between the two notches is at least 1 square. Okay, so you see the M sign, which is this one. On lead V1, do you see this? It goes down. So a normal V1, a P wave on V1 normally looks something like this. Okay, there's shway up, a little slide downward. So when there's left atrium enlargement, the downward is really exaggerated, like what's happening here. Okay, so if you can see that, you see how this one dips down and this one is an M. This is how you diagnose left atrial enlargement. For right atrial enlargement, it does not present this way. Why? Because in the P wave, we said that when there's left atrial enlargement, it takes so long for the left atrium to depolarize. So that's why you get this sign. Okay, it kind of separates, stops being in sync. It takes longer for the left side. So it kind of separates from the first wave. Okay, so it looks like this. But in the right atrial enlargement, what happens is the right atrium is the one that's sending the impulse, with the sinus node and everything. When the right atrium enlarges, it doesn't also separate and causes the M. No, it causes a really strong P wave because there's a stronger impulse or stronger electricity being sent from the right atrium to kind of overcome how big the right atrium is becoming. So on leads 2 and V1, what you will see is a P wave. Remember, we look at lead 2 and V1 for atria. The P wave is so big, it's so high up, okay? That's the first sign. Second sign, on V1 or V2, you see a very, what is it? You also see an enlarged P wave. Okay, so very easy. Basically, in right atrial enlargement, you see enlarged P waves. This is the criteria. More than 2.5 boxes here, more than 1.5 boxes in 1 or 2. In left atrial enlargement, you see the M or the negative deflection on V1. Okay, now, can you tell me what do we have here?
Left atrial. لا.
Left, okay, yes, why?
Lead 2, there is M notch. Yeah.
Yes, what's the other lead that we look at?
V1.
V1, what we're supposed to see on V1?
Negative. يعني the left atrium should be down يعني.
Okay, yes, I don't really see that here. So
Yes,
one is
sorry.
Adi. Yes, so it's either 2 or V1, Adi, okay? Doesn't have to be both.
تمام.
No. Okay, this is
Same
basically...
same as to the right, صح? Either lead
Yes.
2 or V1.
Yes, I put or here.
Okay, تمام.
Okay, tamam. So same thing, right atrial enlargement. Okay, what about here?
Right atrium.
Yes, do you see how big these P waves
Yeah.
are? Yes,
Mm.
so this is right atrial enlargement. Okay, what about this?
Both. Bilateral. Biatrial,
Yes.
sorry.
Yes, exactly, because on lead 2, we see left atrial enlargement.
And
But
also
on
there's a...
Yes, and
Yeah.
on lead V2, we see a really big P wave, so?
Yeah.
So this shows, and there's right atrial enlargement, this shows there's left atrial enlargement. So this is by atrial. Yeah, also there's negative, okay. Now, okay, you guys answered by atrial. So are the atrial enlargements clear? You look at lead 2 or V1,
Yes.
and in case of the right atrium, you look at lead 2 or V1 or V2, okay? Now, for ventricular hypertrophy, we look at the QRS complexes, okay? Now, what's the difference between Wait. Just 1 second. Okay, what's the difference between a bundle branch block and ventricular hypertrophy? In ventricular hypertrophy, the muscle becomes huge. So it's hypertrophy, so there's more muscle. So the impulse is gonna be greater. So the QRS complex is gonna be really big, okay? But in a bundle branch block, there's an increase in the QRS duration. So we're looking more at the width, okay? Because bundle branch block means there's a block in the conduction system of the heart, which means there's slower depolarization, okay? So this means it takes longer to depolarize, which means the QRS will become wider, okay? But in the ventricular hypertrophy, it's actually just stronger contraction, okay? So higher up, really big wave. That's how you can tell them apart in case you are confused. Now, for the ventricles, it's really, really easy. V1 and V2 are for the right ventricle. V4 to V6 are for the left ventricle. Makes sense because V1 and V2 are in the front where we have the right ventricle, and these are on the side where we have the left ventricle. So we need to see changes in V1 and V2. This means right ventricle hypertrophy. If we see the huge QRS in V3, V4, V5, and V6, it means it's left ventricular hypertrophy. Now, okay, this is just showing you the normal. You need to know normal, you need to know abnormal. Now here, can you guys guess what this is?
Right ventricular hypertrophy.
Yes. Do you see how long the QRS is? It's almost reaching, okay, they're really, really long in V1. Yes. But then when you go towards V4, V5, V6, they're kind of becoming shorter. And they're really long in V1 and V2. So we're thinking right ventricular hypertrophy. Okay? So this is basically what they're telling us. The R waves are going to be really positive in the first leads, which are V1 and V2. And then as you move away from the right ventricle, the S waves will become deeper. Not the most important thing to remember, but you'll see it as a pattern. Okay? Okay, so remember the axis deviation? We said we see right axis deviation when we have hypertrophy because now the muscle is so big, you have a lot of electrical activity going on in the right ventricle, so you'll have a right axis deviation. So always when you're solving an ECG that's related to left ventricular hypertrophy or right ventricular hypertrophy, always check the axis with it, okay? Because you'll have an MCQ where it's right ventricular hypertrophy is an option, or right ventricular hypertrophy with right axis deviation is another option, okay? So you need to know if they are in the ECG or not, okay? So, talked about this. Okay, now, how long does it need to be for it to be considered long enough to be hypertrophy? Longer than 7 small squares. That's what you need to remember, okay? The rest, not really important. Okay, not really important. What's this one?
Left ventricle.
Exactly. Do you see how huge they are in 4, 5, and 6, even in 3? But in lead 1, not much. صح? But do you see how deep the S waves are in 1 and 2? So the criteria for left ventricular hypertrophy is a bit different, even though from just looking at the ECG, you can know it. You know, like for exam purposes, it's enough to know and they would be really big on 4, 5, and 6, 3, 4, 5, 6. But the official criteria for it is that the length of the R wave in leads 4 or 5 or 6 or even 3, one of them, the length of the R wave plus the length of the S wave in V1 or V2 would be 35 or more. Okay, so again, this is Q, this is R, and this is S. So in left ventricular hypertrophy, the Q wave would be so long, in V3, 4, 5, or 6. Okay, but the S will be so deep in V1 and V2. If you add one of these plus one of these together, it should be at least 35. You won't really do this. You're not going to count squares. Just by looking at it, you can know. It's just for you to know this is the criteria. Is that clear?
Yes.
Okay. So, for example, this one, you don't have to add and calculate. It's very obvious.
Yeah. There's a ventricle.
Yes. Don't confuse this with model branch blocks, okay? Just be careful. This one as well, very clear. صح? What about this one?
Same.
Same thing as this one.
Same.
Okay, yeah. This is left ventricular hypertrophy. There's also left atrial enlargement and left dilation. Yeah, we know this. Okay. Oops. What's this one?
Both.
Both what?
يعني there is huge in
No,
ventricle.
it's right and left atria. That's what you mean?
Right ventricle.
I mean, no, it's only one. It can't be both right and left ventricles. It's only one. And an easy way to look at this is as soon as you see, they're really long in V1 and V2, even if they're also long in the others, we go with right, okay? Because look at V6, it's really short, and the S waves aren't deep in V1 and V2.
Okay.
Okay, in V1 and V2 لازم ال R تكون كتير قصيرة and the S تكون كتير deep for it to be long. Okay? And you also see in where? In V2 you can see that the P wave is long. Come on. Also here. So this is right atrial enlargement and right ventricular hypertrophy. Okay?
Okay.
The P wave is more clear in lead 2. What about this one?
Left ventricle.
Yes, what else?
And right atrium. No, left atrium.
Okay, here which sign do you see?
The M not.
Yeah, so this is left atrium, صح?
Yeah.
Right, check V2 as well. What do you see?
Inverted. Negatively, yeah.
Yeah, so also left atrium, صح?
Yeah.
Okay, what about V1?
Same.
Yes, okay. 1 second. 1 second. Okay. It's written there's right atrial enlargement here, but I don't see that at all. So, okay, perfect. What about this one?
It is left ventricular hypertrophy.
Okay, what else?
Yeah. I cannot decide صراحة for the
Okay,
actually.
let's do it together. So in lead 2, the P wave is really big, صح? It's high. Okay, so we know the right atrium is enlarged. What about V2? No, not that clear here. What about V1? There's negative deflection, صح? Of the P wave. So this means that the left atrium is also involved. So this is biatrial left ventricular hypertrophy. Why? It's because there's the M or P mitrale or the notch in lead 2, but in lead V1, we see that there's a dip in the P wave down. There's this is a sign for left, both right and left. Okay. Now these are just practice questions that you can. Do you guys want to do them or no? Because class, we're done. Like, if you guys want to do the questions, there are 6 questions.
Left atrial enlargement.
Oh, you're answering which one? This one?
No, the first one that you put.
Oh, okay. Yes, exactly. This one?
Yes.
Okay, yes. This is left atrial enlargement because you see the notch. What about this one?
Right atrial enlargement.
Yes, perfect. Because the P waves in lead 2 are so prominent. Okay, what about this one?
Left ventricular hypertrophy.
Perfect. What about this one?
Anterior lateral, am I?
Okay, which leads are you looking at?
V2, 3, 4, 5.
Okay, yes, I see it in V2, V3, V4, V5, but there's no in V6. Not V6.
So anterior, I guess.
Yes, anterior wall. What about this one?
Fibrillation and atrial fibrillation.
Yes, perfect. You have to be able to recognize this, and it came in the past so many times. What about this one?
Same atrial fibrillation.
Yes, perfect. What about this one?
Sinus tachy.
Yeah.
Why is it tachy? There are 3 squares, even more, between them. Tachy is less than 3 squares.
D.
Okay, D. How do you calculate the rate? Be careful because there are 3 and more. Like there's 3.5 squares between each one. So it's not tachy. Tachy is less than 3 squares. Okay. Now, this is a normal sinus rhythm. Calculate the heart rate. You just divide the number of big squares. 1, 2, 3. It's almost 4, like 3.5 to 4. So 300 divided by 4, that's around 70, so it's D. Okay? Don't ignore these spaces. Like, okay? About this
Okay.
one?
Atrial flutter.
Yes, perfect. Sawtooth. These are all past questions, by the way, not for me. So,
Okay. Nice.
okay. Yes. So, just to see like what really comes up on exams. So this one, last thing, they're very random. So you'll see a U wave we talked about in the beginning. It's a little notch after the T wave. This one is a sign of hypokalemia. And this one, just recognize it. It's you see this in cardiac tamponade. It's called electric alternance. They won't get you this like in a different ECG. It will be copy paste this picture. You just recognize one time it's short, one time it's high, one time it's short, one time it's high. The QRS. Okay, tiny QRS, big, tiny, big, tiny. This is a sign for cardiac tamponade. This is a summary from Rafi's slides also of everything you need to know. Please know this by heart. The arterial supply and which are for which side. So this is a summary of everything we talked about. This is how you can approach an ECG question. And that's it. Do you have any questions?
No, thank you so much, Wallah. Thank you.
You're welcome. If you need anything outside the session, I can answer the questions. Just there's not enough time during the session. But the practice questions that I added extra, if you have any trouble solving them, please reach out to me.
Tamam.
Okay, thank you so much.
You're welcome. Will you send the slides?
I already sent them. Inshallah, they'll send them to the batch soon.
Okay, tamam.
Okay, have a good day.